Have you ever wondered why missing just one epilepsy tablet can sometimes trigger a seizure, or why some epilepsy medicines work perfectly for one patient but not for another? And here's something even more surprising. Stopping an epilepsy medicine suddenly can sometimes lead to severe seizures and serious complications. Today, we're going to learn epilepsy and other seizure disorders in a simple and easy to understand way. So let's get started. First, what is the main goal of epilepsy treatment? The answer is simple. The goal is to prevent seizures from happening. Imagine the brain as a giant electrical network. Normally, electrical signals travel in an organized way. In epilepsy, abnormal electrical discharges can suddenly occur, causing seizures. Antiepileptic medicines help stabilize these electrical signals and reduce the chance of seizures occurring. Now, here's an important principle. Treatment usually does not begin with a high dose. Instead, doctors start with a low dose and increase it gradually over time. This process is called titration. Why do we do this? Because we want to achieve seizure control while minimizing unwanted side effects. The doses increase slowly until one of two things happens. Either the seizures become controlled or significant adverse effects begin to appear. This careful approach helps achieve the best balance between effectiveness and safety. Now let me ask you something. Do you think every seizure is treated with the same medicine? Not at all. Choosing the correct antiepileptic medicine is one of the most important parts of epilepsy management. Several factors must be considered before selecting a treatment. First are seizure-related factors. Healthcare professionals look at the type of seizure and the epilepsy syndrome involved. Then come patient-related factors. These include age, sex, pregnancy potential, coexisting medical conditions, and any other medicines the patient is already taking. Social factors also matter. Education, employment, lifestyle, and personal circumstances can all influence treatment decisions. Every treatment choice involves balancing benefits and risks. The benefits include improved seizure control and a reduced risk of epilepsy-related injury or death. However, there can also be risks such as adverse effects, drug interactions, and potential pregnancy-related complications. Another important concept is adherence. Do you know what adherence means? It simply means taking medicines exactly as prescribed. The fewer doses a patient needs to remember each day, the better the adherence is likely to be. Most antiepileptic medicines are taken twice daily. However, some medicines have a longer half-life and may be suitable for once-daily dosing, often at bedtime. Examples include lamotrigine, perampanel, phenobarbital, and phenytoin. But remember, very large doses may still need to be divided throughout the day to avoid excessive drug levels and side effects. Now, let's discuss what happens when treatment doesn't work. The first step in epilepsy treatment is usually monotherapy. Monotherapy simply means using one antiepileptic medicine. Whenever possible, a single medicine is preferred because it reduces the risk of side effects and drug interactions. If the first medicine successfully controls seizures, treatment is continued. But sometimes things don't go as planned. A medicine may fail because seizures continue despite treatment, or the patient may experience intolerable side effects. When this happens, an alternative monotherapy is usually tried. And here's an important exam point. If the first medicine appears completely ineffective, the diagnosis should be reviewed before making major treatment changes. Sometimes, the problem isn't the medicine. Sometimes the diagnosis itself may need reconsideration. Now imagine a patient needs to switch from one antiepileptic medicine to another. Should the old medicine simply be stopped immediately? Absolutely not. One of the golden rules of epilepsy management is never to stop an antiepileptic medicine suddenly unless specifically instructed by a specialist. Instead, the new medicine is introduced gradually while the old medicine is slowly withdrawn. This helps reduce the risk of breakthrough seizures. Sometimes a single medicine is not enough to control seizures. In these cases, combination therapy may be necessary. Combination therapy means using two or more antiepileptic medicines together. The advantage is improved seizure control. However, there are disadvantages too. The risk of adverse effects increases. Drug interactions become more likely. Treatment can become more complicated. If combination therapy fails, clinicians often return to the treatment plan that previously provided the best balance between effectiveness and tolerability. Remember this important principle. Whenever possible, use a single anti-epileptic medicine. Now let's move on to an important safety warning from the MHRA. All anti-epileptic medicines may slightly increase the risk of suicidal thoughts and self-harming behavior. These symptoms can sometimes appear surprisingly early, even within the first week of treatment. Patients, relatives, and carers should be aware of warning signs such as mood changes, distressing thoughts, or suicidal feelings. If these occur, medical advice should be sought immediately. However, medicines should never be stopped suddenly without professional guidance. Next, let's talk about something many patients find confusing. What happens if the pharmacy gives a different looking tablet? The medicine may be the same, but the manufacturer may be different. For some epilepsy medicines, changing manufacturers can potentially affect seizure control. Because of this, the MHRA groups anti-epileptic medicines into 3 categories. Category 1 medicines should usually remain with the same manufacturer whenever possible. These include carbamazepine, phenobarbital, phenytoin, and primidone. For these medicines, maintaining consistency is especially important. Category 2 medicines require clinical judgment. Examples include clobazam, clonazepam, eslicarbazepine acetate, lamotrigine, oxcarbazepine, perampanel, rufinamide, topiramate, valproate, and zonisamide. The decision depends on factors such as seizure frequency, treatment history, and the consequences of a breakthrough seizure. Category 3 medicines are generally considered suitable for manufacturer switching. Examples include brivaracetam, ethosuximide, gabapentin, lacosamide, levetiracetam, pregabalin, tiagabine, and vigabatrin. Even when switching is considered acceptable, patients may become anxious or confused if tablets suddenly look different. This can sometimes reduce adherence and increase the risk of dosing errors. Now let's discuss a rare but potentially life-threatening condition known as Antiepileptic hypersensitivity syndrome. Although uncommon, this reaction can be extremely serious. It is associated with medicines such as carbamazepine, lacosamide, lamotrigine, oxcarbazepine, phenobarbital, phenytoin, primidone, and rufinamide. The syndrome usually develops between 1 and 8 weeks after starting treatment. The classic warning signs are fever, rash, and lymphadenopathy, which means enlarged lymph nodes. But the condition can become much more severe. The liver, kidneys, lungs, blood cells, and blood vessels may all become involved. In severe cases, multiple organ failure can occur. If hypersensitivity syndrome is suspected, the medicine must be stopped immediately. The patient should never be re-exposed to the same medicine, and specialist advice should be sought urgently. Now let's move on to withdrawal of anti-epileptic medicines. Many people ask whether epilepsy medicines can ever be stopped. The answer is yes, but only in carefully selected situations. Withdrawal may be considered when a patient has remained seizure-free for at least 2 years. However, the risk of seizure recurrence must always be assessed before making any decision. If there is uncertainty, referral to an epilepsy specialist is recommended. Withdrawal must always be gradual. If a patient is taking multiple anti-epileptic medicines, they should be withdrawn one at a time. Never stop all medicines together. And remember, certain medicines require extra caution. Barbiturates and benzodiazepines should never be withdrawn suddenly because severe rebound seizures may occur. For most anti-epileptic medicines, withdrawal should take place over at least 3 months. For barbiturates and benzodiazepines, an even slower withdrawal may be required. If seizures return during withdrawal, the most recent dose reduction should be reversed and specialist advice should be obtained. Let's discuss driving regulations. This is a very important topic in epilepsy management. Whenever a seizure occurs, driving must stop immediately. The relevant driving authorities should also be informed. After a first unprovoked seizure, driving is generally not permitted for 6 months. Driving may resume only if specialist assessment confirms that the risk is sufficiently low. For people with established epilepsy, driving may be allowed if they remain compliant with treatment and have been seizure-free for at least 1 year. In some cases, people with a stable seizure pattern that does not involve loss of consciousness may also be eligible. Sleep seizures have special rules. Generally, driving is not allowed for 1 year unless a clear and established sleep-only seizure pattern exists. Medication changes are also important. Driving should usually be avoided during medicine withdrawal, during major treatment changes, and for 6 months after complete withdrawal of treatment. Now that we understand the foundations of epilepsy management, let's move into one of the most important and frequently examined areas of epilepsy care: pregnancy and breastfeeding. This is a topic that often worries patients. Imagine being a woman with epilepsy who discovers she is pregnant. One of the first questions that comes to mind is, should I stop my epilepsy medicine to protect my baby? The answer is usually no. In fact, stopping treatment suddenly can sometimes be more dangerous than continuing treatment. Let's understand why. All anti-epileptic medicines carry some risk during pregnancy. The greatest risk occurs during the first trimester when the baby's organs are developing. The risk can become even higher when multiple anti-epileptic medicines are used together. This is one reason why monotherapy, using a single medicine whenever possible, remains such an important principle in epilepsy treatment. Now let's talk about the medicine that receives the most attention in pregnancy discussions. That medicine is sodium valproate. Do you know why valproate is such a major concern? Valproate has a high risk of causing birth defects and developmental problems in children exposed during pregnancy. Studies have shown that major congenital malformations occur in approximately 10% of exposed pregnancies. In addition, neurodevelopmental disorders may occur in around 30 to 40% of exposed children. Because of these significant risks, valproate should generally not be used in females of childbearing potential unless the strict requirements of the pregnancy prevention program are met. And during pregnancy, valproate should be avoided whenever a suitable alternative is available. So which medicines are considered safer? Current evidence suggests that lamotrigine and levetiracetam are among the safest anti-epileptic medicines studied during pregnancy. Large studies have not shown an increased risk of major congenital malformations when these medicines are used at usual maintenance doses. They have also not been associated with increased rates of fetal loss, growth restriction, or preterm birth. However, not all medicines carry the same level of safety. Carbamazepine, phenobarbital, phenytoin, and topiramate have all been associated with an increased risk of congenital malformations. For some of these medicines, the risk becomes greater as the dose increases. This is why the lowest effective dose should always be used. Another important point involves drug monitoring during pregnancy. Pregnancy causes many physiological changes within the body. These changes can alter drug concentrations and affect seizure control. Lamotrigine and phenytoin are particularly affected. For this reason, plasma drug levels may need to be monitored throughout pregnancy. Now let's discuss contraception. This area is often overlooked but extremely important. Women of childbearing potential should use highly effective contraception. However, there is a challenge. Some anti-epileptic medicines can reduce the effectiveness of hormonal contraceptives. At the same time, some contraceptives can alter anti-epileptic drug levels. This means careful planning and specialist advice may be needed to ensure both seizure control and reliable contraception. Now imagine that a woman taking anti-epileptic medicine unexpectedly becomes pregnant. Should she immediately stop her treatment? Absolutely not. One of the most important messages in epilepsy management is that anti-epileptic medicines should never be stopped suddenly because of pregnancy. Uncontrolled convulsive seizures may pose a greater danger to both the mother and the baby than the medicine itself. Fortunately, there is some reassuring news. Most women with epilepsy who take anti-epileptic medicines deliver healthy babies. In fact, at least 90% have babies without congenital malformations. To further reduce risk, folic acid supplementation is recommended throughout the first trimester because it helps reduce the risk of neural tube defects. After delivery, routine vitamin K administration to the newborn is recommended because it helps reduce the risk of neonatal hemorrhage. Now let's move on to breastfeeding. Many mothers worry that epilepsy medicines will automatically prevent them from breastfeeding. Fortunately, this is usually not the case. Breastfeeding is generally encouraged for mothers receiving anti-epileptic monotherapy. However, babies should still be monitored carefully. Healthcare professionals watch for signs such as excessive sleepiness, poor feeding, inadequate weight gain, or developmental concerns. Some medicines produce higher levels in breastfed infants. Examples include ethosuximide, lamotrigine, primidone, and zonisamide. Other medicines may increase the risk of infant drowsiness. These include primidone, phenobarbital, and benzodiazepines. Now that we've covered pregnancy and breastfeeding, let's move into seizure-specific treatment. We'll begin with focal seizures. Imagine a seizure that starts in one specific area of the brain rather than involving the entire brain from the beginning. This type of seizure is called a focal seizure. For focal seizures, first-line monotherapy options are lamotrigine or levetiracetam. These are generally the preferred starting treatments. If these medicines are unsuitable or ineffective, second-line monotherapy options include carbamazepine, oxcarbazepine, and zonisamide. A further option is lacosamide, which may be considered as a third-line monotherapy treatment. Sometimes focal seizures remain uncontrolled despite monotherapy. In that situation, adjunctive therapy may be required. First-line adjunctive options include carbamazepine, lacosamide, lamotrigine, levetiracetam, oxcarbazepine, topiramate, and zonisamide. If additional treatment is still needed, second-line adjunctive options include brivaracetam, cenobamate, eslicarbazepine acetate, perampanel, pregabalin, and sodium valproate. Further specialist options include phenobarbital, phenytoin, tiagabine, and vigabatrin. Next, let's discuss generalized tonic-clonic seizures. These are the seizures that many people imagine when they hear the word epilepsy. The entire brain becomes involved, often causing loss of consciousness and widespread muscle contractions. Treatment recommendations depend partly on whether the patient can become pregnant. For males and females who are not able to have children, sodium valproate is considered the first-line treatment. If valproate is unsuitable, lamotrigine or levetiracetam may be used as second-line options. For females who are able to have children, treatment recommendations are different because of the pregnancy risks associated with valproate. In these patients, lamotrigine or levetiracetam are recommended as first-line options. Now let's move on to absent seizures. Have you ever seen a child suddenly stop what they are doing, stare blankly for a few seconds, and then continue as though nothing happened? That is a classic example of an absent seizure. These seizures are often brief and may easily be mistaken for daydreaming. For absent seizures, the first-line treatment is ethosuximide. If ethosuximide is ineffective or unsuitable, sodium valproate is usually considered next. Further options include lamotrigine and levetiracetam. However, some medicines should generally be avoided because they may worsen absent seizures. These include carbamazepine, gabapentin, oxcarbazepine, phenobarbital, phenytoin, pregabalin, tiagabine, and vigabatrin. This is a very important exam point because using the wrong medicine can actually make seizure control worse rather than better. Next, let's discuss myoclonic seizures. Have you ever experienced a sudden muscle jerk just as you're falling asleep? Now imagine that type of sudden jerk occurring repeatedly because of abnormal electrical activity in the brain. That's the basic idea behind myoclonic seizures. These seizures cause sudden, brief muscle jerks that may affect one part of the body or the whole body. For males and females who cannot become pregnant, sodium valproate is usually the first-line treatment. If valproate is unsuitable, levetiracetam is generally considered the second-line option. For females who can become pregnant, levetiracetam becomes the preferred first-line treatment because of the pregnancy risks associated with valproate. Other possible treatment options include brivaracetam, clobazam, clonazepam, lamotrigine, phenobarbital, piracetam, topiramate, and zonisamide. Now here's an important exam point. Some medicines can actually make myoclonic seizures worse. These include carbamazepine, gabapentin, oxcarbazepine, phenytoin, pregabalin, tiagabine, and vigabatrin. Even lamotrigine, although useful in many seizure types, may occasionally worsen myoclonic seizures in some patients. Next, let's discuss atonic and tonic seizures. Imagine the brain suddenly sending abnormal signals that cause a person either to lose muscle tone completely or become suddenly stiff. An atonic seizure may cause a sudden collapse because muscle tone is lost. A tonic seizure causes sudden muscle stiffening. Because these seizures can lead to falls and injuries, good seizure control is very important. For males and females who cannot become pregnant, sodium valproate is usually the first-line treatment. Lamotrigine is generally used as a second-line option. For females who can become pregnant, lamotrigine is preferred as first-line treatment. Additional options include clobazam, rufinamide, and topiramate. In particularly difficult cases, felbamate may be used under specialist supervision as a last resort treatment. Now let's move on to Dravet syndrome. Dravet syndrome is a severe epilepsy syndrome that usually begins during infancy and requires specialist management. Because this condition can be difficult to control, treatment decisions should always involve a specialist neurologist. The usual first-line treatment is sodium valproate. If seizure control remains inadequate, a combination of clobazam, stiripentol, and valproate may be used. Additional options include cannabidiol combined with clobazam, fenfluramine, topiramate, levetiracetam, and potassium bromide. Now here's something very important. Several medicines should be avoided because they can worsen seizures in Dravet syndrome. These include carbamazepine, gabapentin, lacosamide, lamotrigine, oxcarbazepine, phenobarbital, pregabalin, tiagabine, and vigabatrin. Next, let's discuss Lennox-Gastaut Syndrome. This is another severe epilepsy syndrome that can be extremely challenging to manage. Patients often experience multiple seizure types and may require long-term specialist care. The usual first-line treatment is sodium valproate. If additional treatment is required, lamotrigine is often used as a second-line option. Further treatment options include cannabidiol combined with clobazam, clobazam alone, rufinamide, and topiramate. For severe resistant cases, felbamate may be considered under specialist supervision. Now let's talk about cluster seizures and prolonged seizures. Imagine a patient experiencing multiple seizures over a short period of time. For example, 3 or more seizures within 24 hours. Or imagine a seizure that simply doesn't stop when it should. These situations are medical emergencies. Whenever possible, the patient's individual emergency plan should be followed. If an emergency plan is not available, benzodiazepines are commonly used. Examples include clobazam and midazolam. Now we arrive at one of the most important emergencies in epilepsy, convulsive status epilepticus. Do you know why status epilepticus is considered so dangerous? Because ongoing seizure activity can cause brain injury and become life-threatening if not treated quickly. Convulsive status epilepticus is generally defined as a seizure lasting 5 minutes or longer. This is a medical emergency. Immediate management follows the ABC approach. First, protect the airway. Second, provide oxygen and support breathing. Third, maintain blood pressure and circulation. Blood glucose should also be checked because hypoglycemia can trigger or worsen seizures. Special situations must also be considered. If alcohol misuse is suspected, thiamine may be required. If pyridoxine deficiency is present, pyridoxine should be given. Now let's discuss emergency treatment. In the community setting, first-line treatment is usually buccal midazolam or rectal diazepam. If the patient is in hospital and intravenous access is available, intravenous lorazepam is commonly used. But what if the first dose doesn't work? A second benzodiazepine dose may be given within 5 to 10 minutes. If seizures continue, second-line treatment is required. Options include levetiracetam, phenytoin, or sodium valproate. If seizure activity still persists, third-line treatment may be necessary. This may involve phenobarbital or even general anesthesia under expert supervision. Now let's briefly discuss non-convulsive status epilepticus. Unlike convulsive status epilepticus, these patients may not show dramatic shaking movements. Instead, they may have altered awareness or prolonged confusion. If awareness is only partially affected, oral anti-epileptic treatment may simply be continued. More severe cases are generally managed in a similar way to convulsive status epilepticus. However, general anesthesia is rarely required. Finally, let's discuss febrile convulsions. Many parents become frightened when a child develops a seizure during a fever. Fortunately, most febrile convulsions are brief and self-limiting. For short febrile convulsions, specific anticonvulsant treatment is usually not required. Paracetamol is often used to reduce fever, although evidence that it prevents further convulsions is limited. However, prolonged febrile convulsions require more urgent attention. If a febrile convulsion lasts 5 minutes or longer, or if repeated convulsions occur without recovery between episodes, the situation should be treated as convulsive status epilepticus. One final question. Should children with febrile convulsions receive long-term anti-epileptic treatment to prevent future episodes? In most cases, the answer is no. Long-term prophylactic treatment is usually not required. And that brings us to the end of epilepsy and other seizure disorders. Today we've covered treatment goals, medicine selection, pregnancy, breastfeeding, focal seizures, generalized seizures, absence seizures, myoclonic seizures, atonic and tonic seizures, Dravet syndrome, Lennox-Gastaut syndrome, cluster seizures, status epilepticus, and febrile convulsions. Most importantly, remember that successful epilepsy management is not simply about choosing a medicine. It's about selecting the right medicine for the right seizure type, ensuring good adherence, monitoring safety, and supporting patients throughout their treatment journey. If you found this video helpful, please like, share, and subscribe for more learning videos. And in our next video, we'll start a brand new topic from the nervous system chapter, anxiety. I'll see you in the next lesson.